You now, live chair.
Thank you, Gordon.
I'll leave you to it and hand back over to you.
Okay, welcome to September's Rotherham CCG governing body meeting. We have a number of apologies, because it's bank holiday week. So we've got apologies from John Barber, Ben Atkinson, Councillor Roach, who is just on his way on the holiday. He's just been picked up, I think. Jeff Avery and Simon McEwen. We have a quorum because Jeff and Simon and the rest of the members group nominated David to be their representative at today's meeting. Janet's managed to leave the meeting and I'll need to readmit her. So we'll just pause there while Janet comes back in.
And Lindsay, can we just make sure we're recording the notes that Dr. Clitheroe is here as the members committee representative, just so it's clear. Okay, thank you.
Yeah, I've got it. Thank you.
Janet, are you back with us?
I'm back. I'm back.
Okay, that's fine. We'll just do a quick round of introductions. So I'm Richard Cullen, I'm chair of Rotherham CCG. Ruth?
Ruth Brown, assistant chief officer.
Ryan?
Ryan DeCosta, secondary care representative.
Chris?
Chris Edwards, accountable officer.
Debbie?
Debbie Twell, lay member.
David?
David Clitheroe, GP, and also representing GPMC.
Jason?
Jason Page, GP and Vice Chair at CCG.
Ian?
Ian Atkinson, Exec Place Director at CCG.
Sue?
Good afternoon. I'm Sue Caston. I'm the chief nurse at the CCG.
Wendy?
Good afternoon. I'm Wendy Allett, chief finance officer.
Janet?
Good afternoon, Janet Weekly, lay member and chair of primary care committee.
And Lindsay?
Rotherham CCG minute taker.
Okay, thank you. We are court. Any declarations of interest? Okay. Any patient or public question? Oh, sorry, Jason, you put your hand up.
Sorry, Richard, I just need to say that I'm the clinical director for Doncaster's Lung Health Check programme when we go through that, so I do have a slight interest there compared to standard. Thank you.
Okay, thanks. Any patient or public questions?
No, Chair, we've not received any.
Okay. Right, minutes of July's meeting for accuracy and any matters that arise that aren't on the agenda or the action log. Page 1. 2. 3. Sue?
It was just a comment on page 3 that I thought could be a little bit clearer. So it's under communications, after the first 2 bullets, Mr. Anderson informed members that vaccination case data shows that rates are now much lower for double vaccinated people. I think that needs to read, Mr. Anderson informed members that infection case data shows that rates are now much lower for double vaccinated people.
Okay, that's a good amendment. Okay, moving on, page 4. 5. 6. 7. 8. 9. 10. 11, 12, 13, 14, and 15. Okay, thank you, Lindsay. They're an accurate record.
Thank you.
Just moving on to the action log. David, Ryan, did you catch up after the meeting?
No, I haven't, I'm afraid. That's to be done.
My item is still in progress because there's also just an engagement process moment for actually standardising appointment details in the national thing, so that is in process. Then Ian.
Just on that final note, Chair, that was around the Commission for Outcomes work that was trying to be taken through consistently. I think there was a query around whether JCCG had received the paper also, which, to the best of my knowledge, they have done that as well. So I think we're good to approve that as per last time's discussion, if that's okay, Chair.
Okay, thanks. We shall move on then to a rather extensive Chief Officer's report, Chris, as we move and transition. These will become obviously quite extensive to keep us all informed. Over to you, Chris.
Okay, thanks. Afternoon, everybody. So yeah, it's a longer than usual report as we move into the next phase. I guess from the September to March phase, as we transition to ICSs, the report will naturally be longer because national guidance is coming thick and fast. So I'll just methodically go through, Chair. If there's any questions, do you want to wait to the end, or shall I pause at the end of every item with it being such a long report?
I think if you just pause every 2 or 3 items.
Okay, okay. So the first item is the CCG annual assessment. So historically, we've had a rating system where we're currently rated outstanding by NHS England. This year was a slightly revised approach due to the transition and then the pandemic situation. So myself and Dr. Page took part in an assessment. Basically, we received the letter. The letter's included in the papers. The letter summarises 5 key areas around improving the quality of service, reducing health inequalities, involving and consulting the public, complying with financial duties and leadership and governance. Overall, the letter talks about the CCGs played a key role in supporting the NHS and South Yorkshire and Bassetlaw to respond effectively to the COVID-19 pandemic, and had effective leadership of the CCG is also fundamental to the local place and wider ICS recovery plan. So overall, a very positive assessment, a positive feedback. We don't get an official rating this time, so this letter will be that. So that is our, we'll go in with our annual report. So again, just thank you to all our staff and all our stakeholders for helping us during that year. The next piece of business is the integrated care system announcement of boundaries just changes. So we've been waiting for some while. There's been a long-standing discussion about the Bassetlaw health system and whether it sits in Nottinghamshire or South Yorkshire and Bassetlaw. It crosses boundaries in terms of patient flows. So it's always been one which there's not been an obvious solution. Following consideration by the Secretary of State, the decision's been taken that from the 1st of April 2022, the Bassetlaw Health System will join the Nottinghamshire Integrated Care System as it takes statutory form. So as we transition, assuming that we receive parliamentary approval for the bill, we would now transition into the South Yorkshire Integrated Care System. So business as usual now for 21-22, but as we plan for 22 and beyond, Bassetlaw will be planning to head towards the Nottinghamshire Integrated Care System. Moving on to our South Yorkshire Integrated Care System as it will be, an independent chair has been appointed. There was a robust selection process and the appointment has been made of Piers Butler. He's previously held chair positions at Blackpool Teaching Hospitals and University Hospitals of Morecambe Bay. And I believe he's joining us this month, so we'll be meeting him soon. In terms of integrated care systems and guidance, we've been promising guidance for some time, and the timescales have slipped a little. But during August, there was a sort of a mass publication of documents. So obviously, I'd encourage people to read the documents separately, but I'll just do a quick summary of the documents that have been published so everyone knows what we've got. So the first document published was interim guidance on the functions and governance of an integrated care board. So this describes what a statutory ICS will need to have in order to discharge its functions. And it talks about this list of statutory duties, the CCG functions and how they'll transfer to integrated care boards. And also it talks about a draft model constitution, which an integrated care system in South Yorkshire will need to have as well. The second document was the Human Resources Framework for developing integrated care boards. And this talks about practical support for NHS organisations affected by change, like CCGs, And the guidance is designed for all ICS partners and leads, CCG accountable officers to help people manage the development of integrated care boards from a HR perspective. I'll keep going. The third document is Building Strong Integrated Care Systems Everywhere, guidance on the ICS people function. And this builds on the priorities set out in the people plan. And it talks about how helps NHS system leaders and their partners to support the one workforce approach by delivering key-based people outcome functions from April 2022. The next document that was published is the ICS implementation guidance, integrated care board readiness to an operating statement and checklist. Again, this provides a template for the readiness to operate the systems going forward to the formation of an ICS on the 1st of April 2022. And finally, it's the ICS implementation guidance, due diligence, transfer of people and property from CCGs to ICBs and CCG close down. And this is guidance designed for CCGs and ICS teams to work together to ensure a smooth transition between our organisational change. So they'll be the first of many documents coming out. Please do read them. If I get any summaries through from places like the NHS Confederation, I will circulate them to governing body members. Hopefully there'll be some shorter summary documents. But the key one to flag up is the HR framework. It is a 59-page document. I would flag up the frequently asked questions section for age 49 to 59 as sort of quite a good summary area to look if people are just going to have a quick look at the document. But it will be a key document for us to use over the coming months. But it's really about how we can make sure that we transition safely our staff, our assets, from CCGs to integrated care boards, and a clear national approach, and clears out the actions required. So I won't go into detail on those. We've got a development session for the governing body set aside where we can go into these documents in more detail when we next meet. But in just turn to today, Richard, I'll just pause there, see if there's any questions on any of those documents.
Thanks, Chris. Any questions?
And the governing body members happy that the proposal that we use our development session next month to go through these in more detail, so it gives people time to read the documents and we can go through them in a dedicated session. Okay.
Seeing a thumbs up, Chris, there seems like
I've got one thumbs up. I'll take that as approval then. Okay, thank you. I'll keep going with the Chief Officer's report. The next item is the COVID pandemic inquiry. Again, this has been announced in Parliament, but the exact aims and the remit, the terms of reference haven't been announced, and they've said they'll be announced early next year. Obviously, we've started preparations and we'll be ready to respond to any inquiry, but it's going to be quite a lengthy process, I would imagine. So we'll just make sure that we're organised. And just to flag up that Ian as Executive Place Director and Ruth as Assistant Chief Officer will be our leads for liaising with the inquiry. Next,
Debbie.
Sorry, Debbie, I've got a hand up.
Sorry, I was just going to ask, I mean, obviously that's next spring when the CCG will no longer exist in principle, will it? So presumably they're going to make some sort of arrangements for that information to be able to flow out from CCGs as to what's going to happen into the inquiry. I don't know.
Yeah, so what we'll need to do, Debbie, is all information that we hold as an organisation, we'll have to make sure it transitions into the ICB as it comes. So we'll have to make sure as part of our legacy documentation, anything relating to the inquiry will need to be preserved and passed on. Absolutely. Yeah, like it's the chance of it being concluded by 1st of April next year. I would imagine that's probably not very likely. So yeah. So just moving on to the Rotherham Adult Autism Spectrum Disorder pathway expansion. I don't know, Ian, do you want to just mention about this one?
Yeah, just briefly if I can, Chair. So members will remember we approved the development of an all-age neurodevelopmental pathway for children, people and adults, and have invested in both those pathways recently. The adult pathway has seen additional activity in terms of referral and support being required, and we've, as part of our kind of planning element, we've increased the the activity through the contract with Ardash, and this just reflects that additionality through there for the adults. We're also doing a lot of work at the moment around the children's element, which governing body will be receiving further information about when we come back in November in the public domain. So just to know that. Thanks, Chris.
Okay, thank you. So just moving on, there's a couple of contractual arrangements just to report to governing body. So the Roaming Nights Care Service, we did extend the contract for a further 6 months to allow a competitive procurement process. We've now run that process, and the Roaming Nights Care Service will now be resulted in Comfort Call Limited being the recommended bidder. So that will now be enacted, and the contract will commence on the 1st of October 2021 with a contract term of 3 years. With an option of extension for 2 years. So that's the Roaming Nights Care Service. There's also another contractual issue just to report to governing body is the proposal to extend non-emergency patient transport service contracts. So again, due to the COVID impact, we've tried to work with the transport providers to do this. And we've got demand activity forecasts for the next 5 years. And overall, the decision was made by Sheffield CCG as lead to the Yorkshire Ambulance Service to extend the contract by 12 months, publishing a VEET notice. And VEET stands for, I can't remember. Wendy, help me. What does VEET stand for?
I think it's voluntary ex-ante transparency or something close to that.
In my language, it's a transparency notice, but Wendy's just obviously giving you the proper, apologies for using an acronym in the paper, but a VEET notice, a transparency notice to ensure that people are aware of the rationale for our decision making. We're also just asking the governing body to support the decision made by Sheffield CCG, to support the decision made by Doncaster CCG as prime lead to Primary Care Direct to extend the contract by 11 months and again publish a transparency notice, to support the extension of First for Care on the day discharge contract for 12 months, and support the South Yorkshire and Bassetlaw CCG's contracting team to work with the procurement team to establish a transparency notice to the marketplace and work with current providers of extended service provision. So there's just a recognition that transport service has been a real challenge during COVID. So we've had to make some contract extensions with transparency notices. So if governing body members are happy, if we could just record that we supported those decisions. Happy to take questions if people want more detail on that.
Is everyone happy with that? I'm getting thumbs up.
Okay, thanks everybody. So if we could just record, Lindsay, that we had support on those 4 bullets that I've just read out in terms of the notes. I'll just move on to the South Yorkshire and Bassetlaw Primary Care Capital Schemes. Again, just to report that the Rotherham projects are Waverley Medical Centre and Broom Lane Medical Centre, and the project initiation documents now being finalised, and a programme business case will go through Treasury. But everything is going to plan, and we would hope that those 2 improvements to our primary care estate will go forward for funding and hopefully implementation before the end of 2023. COVID-19 incident control team. What we did is we have a Rotherham Gold Command, and what we do is, as part of that, we have a CCG internal incident control team to make sure that we're absolutely in control of the pandemic and the challenges it brings to us. Well, I think we probably refer to it as Wave 3 in South Yorkshire. It might have been Wave 2 in other areas of the country, but as the wave came through, we reinstated Gold Command and the ICT as part of system pressures. But we've taken the decision now to stand down, as we're now in sort of business as usual as we come through, as the NHS is in recovery mode, and we work through to try and understand what business as usual is going forward. That said, I think system pressures remain, and we will keep a very close eye on this in terms of whether we have an incident control team internally and Gold Command in Rotherham. Hospital admissions and winter pressures may well cause us to reenact them at some time, but currently the judgment is made that it's not required, but we take a weekly review of it. Okay, just on to communications update. So again, the COVID-19 vaccination campaign, We're now encouraging, obviously, everybody to have a vaccination, but particularly 16 to 17-year-olds of the new cohort. And we'll be expecting a decision and advice on 12 to 15-year-olds shortly. Progress on 16 to 17-year-olds has been excellent to date. I think we've got around a third of 16 to 17-year-olds vaccinated already. Again, we want to keep advice, even though COVID restrictions nationally aren't required by law, we're still encouraging people to follow the hands, face, space guidance wherever possible. And obviously, as our health services across the board are absolutely under pressure, we're trying to make sure we can work with patients to help them get to the right place first time, using NHS 111 and pharmacy as the first point of access for health needs. And also, just finally, we're working with local partners to develop an anxiety campaign for Rotherham to help people to get support and advice when we need it. There's a recognition that the lockdowns and the effect of COVID has had a unique impact on mental health issues, particularly anxiety. And the campaign seen as an important tool to help people during the pandemic and post-pandemic, as the restrictions are no longer in place. So I shall stop there and see if there's any questions, Chair.
Okay, any further questions for Chris on any of those items? Okay. It's still with you then, Chris.
So, just bear with me a second. So, just coming through. So, the next agenda item is a South Yorkshire and Bassetlaw Integrated Care System update. I think I've covered that as part of my report, Chair. So, I'm happy I've covered that. So, I'm going to move straight on to the Joint Committee of Clinical Commissioning Groups and the proposal for delegation and the transition arrangements from September 21 to March 2022. So in our pack, you should have a paper, which is a paper that's a proposal to CCG governing bodies to supplement the delegation to the Joint Committee of CCG. So just for clarity, that's a committee formed by Rotherham, Doncaster, Sheffield, Barnsley and Bassetlaw CCGs. And we also have North Derbyshire and Mid Yorks as associate, Wakefield as associate CCGs to us as well. And the idea is we make decisions together to make sure that everyone moves at the same pace and we have consistency across our patch to make sure we're all doing serving patients in the same way. So the summary of the key points, I'll just move straight to that section if that's okay. So we're expanding the scope of the delegation. So as we've used hyperacute stroke and children's surgery in two examples of where we've delegated to the Joint Committee previously. But we're looking to expand the scope in its delegation to include transitions such as the carrying out of due diligence, development of corporate policies and development of the constitution of the new Integrated Care Board and liaising with NHS England regarding the constitution. So in my words, that'll be talking about where we're setting up arrangements to start an integrated care board within a South Yorkshire and Bassetlaw integrated care system, a South Yorkshire integrated care system. We'd look to do it once at the Joint Committee of CCGs. So that's the proposal. The national documentation does require us to work as a system in the September to March window. So we're following the national guidance. We're trying to do it in a way we think makes sense for South Yorkshire. There's a recognition that Bassetlaw will need to be present during this, but there's a recognition that Bassetlaw will need to be party to some decisions, but may choose to exclude themselves from other decisions as they move into another integrated care system. We'd be looking to inviting members of the Integrated Care Board to its meetings, so we've got full understanding of the preparatory work done by the Joint Committee, establishing a subcommittee to carry out the work. So the subcommittee we're talking about is a transition board, and we'd have work streams such as finance, governance, quality and safeguarding, finance and estates, all sitting below that. And so we do assurance about the design in the future would go to the transition board at the Joint Committee, but I'd also look to throw it through this governing body and perhaps our audit committee as well. And that's something I'd like to pick up at our development session next time about how we manage that. How do we excuse me. How we as a governing body, sorry, I'm choking.
Right, luckily, Wendy's right there outside the room. I have to go and listen.
Excuse me. As a governing body and a joint committee, and an audit committee can make sure that we oversee the transition in a seamless way. So I think having a part of this arrangement with Bassett Law, again, will work. Bassett Law will be a vital partner designing it, but there'll be parts where they wish to not engage. We're talking about Bassett Law CCG will continue to be a member, but the CCG will be required in order for the meetings of the joint committee to be present. But they'll judge as by topic what it will mean, whether we're quorate or not. So an example of that would be staff transition, overseeing safe staff transition. It's absolutely essential. Bassett Law CCG would be part of that. But if it was something that was designing the South Yorkshire ICS post 1st of April 2022 when Bassett Law gone to Nottinghamshire, then they may choose not to be part of that conversation. The paper's been supported by the 4 South Yorkshire CCGs as a variation to manual delegation. The proposal is it will go to joint committee for final sign-off, but it's coming to each governing body for feedback to make sure that every governing body is comfortable with the delegation before we make a final sign-off. So 2 recommendations. We're proposing amendment to the delegation and establishment of a joint committee of a subcommittee, a change and transition board. And this would be a time-limited transition board to work between September and March. Dr. Cullen, have I missed anything?
I don't think you missed anything, Chris.
And apologies for choking.
Yeah. Well, apologies accepted. You're still alive, so we're fine. The problem with remote viewing, isn't it, is that you start panicking. That's having a problem. Luckily, you are in the office, so as I said, Wendy was around the corner to help you if you struggle. Thanks, Chris. So recommendation 1, are we all happy with that? Any questions about that? Any points anyone wants to make? Okay. So I'm not seeing anyone disagreeing with that. So we have agreed recommendation 1 and then recommendation 2. Everyone happy with that?
So just Chair, just to summarise on a practical basis, what we'll see is the joint committee will take on the delegated responsibility to do that piece of work. But I think it's in the guidance, but I'd also expect this as good practice anyway. And I know the lay members have raised this with me as well, is I would expect the work of the Change and Transition Board to be communicated to our governing body and to our audit committee so we can assure ourselves and oversee that appropriate transition work's being done. So what I suggest is that if we can use our development session next time to talk about what the governing body would wish to see, what's appropriate to go to audit committee, but we're thinking certainly the work streams would have regular progress reports and there'd be a development plan and development achievement reported regularly. That's the outline of the plan. Okay.
Okay, thanks, Chris. Right. Okay, over to Jason for lung health checks.
Everyone. So lung health checks are for patients aged 55 to 74-year-old who have ever smoked, with an aim to pick up lung cancers early and look at other lung health conditions as well. I work 1 day a week for Doncaster as their clinical director on this programme. And we've just started picking up some cancers, so it's working relatively well. Rotherham's rate of lung cancer was slightly below that of Doncaster, so it wasn't offered opportunity to take on lung health checks in the first wave. But now we have been asked to, if we want to be involved in this project, and the first indication from Rotherham is that we are interested. There hasn't been any final decision as yet as to whether Rotherham will be definitely offered the opportunity to take on lung health checks, but a decision is expected centrally. I'm told it's with the finance team at an NHSE at the moment. So we're expecting to hear definitely whether or not we will be invited to take on the lung health checks. There's quite a bit of detail in the paper, so I'm happy just to take questions, really, Richard, for those. I know some people know more about it than others, but I think for those who haven't been involved or heard of it so far, essentially think of it like a targeted screening program. So, with the idea to pick up cancers early. So far in Doncaster, we've picked up 8 lung cancers and a breast cancer. I think about 15 people currently going through the sort of the cancer investigation route. So we've been relatively successful so far, but that's out of about 1,400 scans so far. So, it's a lot of work for relatively few cancers, but it's recommended by NHSE, and it's likely that this will become part of a national screening programme in due course. So generally, I would suggest it's good to be on this early. But happy to take questions, essentially.
Okay, Ryan and then Debbie.
Hi, Jason. I just wanted to ask you about, as in all screening programs, as you're aware, the people who actually really need the screening, they don't engage with the screening program, and what's being done to perhaps kind of pick up on those people, because I'm sure from the data that you've presented, the number of patients that you're picking up for so many scans that have been done, it looks like there is perhaps a lot of people turning up and having scans who perhaps are at lower risk as well. So, is there any work being done to pick up on those people who are probably going to be at higher risk and those who do not engage?
Well, I mean, in Rotherham, no work has been done yet because this is just the suggestion that we'll take on this. In Doncaster, yeah, we've done multiple comms, local advertising campaigns, done some radio. There's everybody gets 2 letters plus up to 3 phone calls to offer them this. So there's quite a lot of effort goes in to make sure that people do attend. That having said, there's a take-up rate of around 50%. Around 50% of people that turn up are eligible for a CT. So not everybody who does this is eligible for a CT. There is a risk scoring in this. So only if you've smoked for a certain length of time and you've got other, there's a sort of a calculation in there that the nurses do. So not everybody automatically does get a CT scan. The expectation is about 3% of people will have cancer, and we're below that in Doncaster at the moment. But we haven't got to the end of the process yet, and some people are having second scans after 3 months with lung nodules, so they may well have cancers that at the moment, we're waiting to see whether the nodules are growing or not. So at the moment we're a little bit behind on the rate, but I suspect by the end we'll be there or thereabouts.
Thank you.
Okay, Debbie, your hand's gone down. Were you going to ask?
Very similar. I was just going to really ask. I think Jason's explained that, whether it was self-referral or GP referral into the pathway. So I think you've kind of covered it, haven't you? It's
what we do is we take the information from GP records as to those people who've ever smoked. That's provided an interesting thing in Doncaster, whereas the information GP records obviously isn't always accurate. So we're finding around 10 to 15% of people who are recorded as having smoked in GP records, when we contact them, say they have never smoked. So we're contacting more people than claim they've smoked. Now, whether that's the patients being accurate or the GP records, that's open for debate. But so there was an issue in Doncaster records there. I would expect the same in Rotherham, because other areas are reporting the same, that are doing this around the country. But fundamentally, the team that we've got, we've sort of used letters, we've used phone calls so people are invited. Then in Doncaster, we've also used a text message to everybody in the age group, whether they've smoked or not, to say, this is available, would you like to come for it, to try and pick up those people that are incorrectly coded the other way, who are down as never smoked but perhaps have smoked. So there's lots of comms, that we've used quite a lot of stuff. I mean, you can always do more, can't you, in these circumstances, but we're about where we should be based on the national expectations in Doncaster. So, we're obviously about where we should be.
Is it open to more than just smokers, Jason?
No, you have to have smoked. You have to have smoked at some point in your life for it to be available.
Yeah, I was just wondering about, people have been in very heavy industry and things like that.
But unfortunately, though, that hasn't been considered, and whether it's early days for this lung health screening. So whether that'll be included down the line, I don't know. But at the moment, it's just for smokers. So no, they haven't thought about our steel workers and coal miners and all that sort of thing.
Okay.
So I mean, at the moment, Richard, we're waiting for a yes or no, which has been coming every week for about the past 6 weeks as to whether it's coming. It's obviously holiday time, so obviously as soon as we get some information, we'll let you know. The assumption is that we will obviously be taking this up as it's been recommended, discussed at OE recommended, but we'll have to get a project team together. My hope would be, but it would depend on procurement rules, that essentially the truck that is used in Doncaster and the team of staff we've got there would essentially move to Rotherham. And this may also be done in conjunction with Barnsley. So just essentially keep moving that truck around the place and keep scanning in different places around the town. But there'll be some procurement exercise we'll probably have to go through just to make sure that's allowed. It's exciting. I mean, I've talked to a couple of people now that have had surgery after their stage 1 lung cancer, which they may well have died from if this hadn't happened. So, that's quite exciting to do that sort of thing.
I think that's the ultimate thing, isn't it? We're finding lung cancers that can be cured. And that's just got to be the real thread through here. This is something that will save lives, definitely. Because lung cancer, when it progresses, is just going to cause you problems and you're not going to recover from it. But if we get you out that stage 1, we can cure it. And it is a huge problem in South Yorkshire, especially in Rotherham and Doncaster. Having been the cancer lead a long time ago, trying to do things before they'd done the research to do things like this. But yeah, so I think thanks for that. I think we, as a board, would fully support that. If it comes into Rotherham or we get selected, it will help our population.
Thank you.
Okay. Performance reports then, Wendy.
Thanks, Chair. Good afternoon, everyone. So we've got the month 4 finance position today. And just before we get going, because the last report you saw was at month 2, if you look into section 5 of the report and the big table, there's 2 extra columns on there this month. So on the far right-hand side, the first of those would give you what we were forecasting at month 2. And then the second shows the variance from what we're now forecasting to that. So if you were to focus on anything and you looked at that far right-hand column, that would give you where the big shifts in financial performance have been. So I hope that helps with the rest of the report. So just in summary then, sections 2 and 3 this month, giving us cash and payments. And both those areas still indicating strong management of those areas, and we are continuing to achieve the 100% compliance against the national payment targets, which, if you remember, are now that we need to pay valid invoices within 7 days. Those are still being strongly pushed by the national team. In terms of operational performance then, and if we hop to table 5, section 5, we're still on track to deliver our 6-month forecast outturn, but it is with increased risk now. And what's essentially happened is there are 2 significant, or possibly 3 significant lines of variance. So concentrating on that right-hand column, you'll see we've got a big shift in the forecast spend on mental health and LD in our other providers. We've had a big shift in CHC. Both of those are overspend positions or beyond our forecast. But we've had some slightly better news on prescribing. The net effect of that is how we've managed to still say that we think we will break even at month 6 is we have effectively now used all of our contingency. And we've also used the funds that we got through an elective recovery fund. And what that means is that now any variation from that forecast outturn means we need to look elsewhere in the financial position. So what myself and the team are doing is in month now, we are reviewing as we go to find any further flexibilities that we might plough into this position, because in fact, what we are seeing is that the nature of patients in the system are more complex. They're coming in higher numbers in CHC and in mental health and LD placements. And it's unfortunately likely, I think, that current forecast will be exceeded, but I don't think by the same magnitude, order of magnitude. So that's the position. In terms of there is more narrative in the report, more detailed narrative on those higher risk areas, I guess. But if I just pause there, and as always, I'm happy to take any questions now.
Okay, thanks, Wendy. Any questions for Wendy? Sue?
Just a quick question, Wendy, and I'm sure you've told me this before, so I'm sorry, but is section 117 included under other providers, mental health and LD?
It is, Sue, yes, it is, yeah. And sorry, I should have said actually, Sue, in that, because we are really actively managing that position as a CCG, aren't we? I mean, it's not like this is going off, you know, it's gone beyond our forecast, but that is because the numbers of patients in the system are just well beyond anything that we have seen. And yes, the section 117 team are strongly, actively case managing these patients for us. Same with the CHC team, and we've put extra resource into there, haven't we, Sue, to help mitigate the financial risk of this. But again, this is being very actively managed by the operational teams.
Okay, any other questions for Wendy? Okay, anything else you want to add in, Wendy?
Can't think of anything, Richard, thanks.
Okay, moving on then to delivery dashboarding.
Yeah, thanks, Richard, and thanks, everyone. So, as I've done in previous recent meetings, I'll just give a bit of an oversight on the COVID position of vaccination that helps set the context of the performance, if that's okay, Chair. So, just a couple of things for colleagues to know is that we are, in terms of COVID prevalence, really quite high in South Yorkshire and also in Rotherham. Current position is 402 per 100,000 prevalence in the community, which is a very high number for us. And what we have therefore seen is a correlation with hospital admissions since we last met. And as of today, there's 71 COVID positive patients in the Rotherham Hospital, which is around, for context, 17% of the bed base, and at the same level as it was in the first part of the pandemic. So there's some real pressure in our system, not just in the hospital setting, but across mental health and primary care. Going back to what Chris was describing in terms of trying to recover services while at the same time dealing with higher levels of COVID than in other parts of the country. So in terms of the kind of performance position, some of this performance position is reported into June and July, and obviously we're now in September, which is the here and now, but it will just reflect where we are as a place and as a system. Just to flag some things by exception, as we usually do, Chair, our A&E numbers are back to the levels that they were previously. In fact, they're higher than some of the levels that we've seen. We've continued, as I reported last time, to see high levels of A&E attendances. But linked to that, we have kind of seen sustained views in terms of sustained attendances, should I say, in line with what we'd expect during a normal winter period. So becoming routine to receive over 300 patients in our urgent emergency care setting on a daily basis. Some of our positives on performance, governing body members will note the discussion that we had previously around trying to recover our elective position in Rotherham, and on the whole, colleagues have done a fantastic job in trying to get through as much elective activity as possible. You'll see from the performance report that we are recovering in that space on the 18-week wait performance, and actually fourth in the country in terms of that position running into June. I've not seen the latest July position, but given the challenges that we're seeing on COVID, it wouldn't surprise me if that remained an increasing challenge as we move forward to hold that elective position. 52-week waiters, we reported the last time we met, we had 472 in the borough. That's come down to 296. So we are making inroads into those 52-week waiters as we'd want to do. In mental health, we're holding our eye at performance, but there's a lot of pressure on our mental health services. I know GP colleagues report a lot of presentation around requiring support for mental health. We have commissioned additional support via IESO, and obviously RDASH delivering some really positive work there across our IAP pathways. Areas of challenge remain on our diagnostic parts of our pathway, our 6-week wait diagnostics. We also see that our cancer performance still remains really challenged in the system. So on the whole, a challenging position with managing COVID and the pandemic. Also challenges across the performance dashboard, but some real signs of improvement in that space. We'll now work really close to see if we can hold that performance in what is a really challenging period and obviously going into winter. So I think that just summarises where I think we are, Chair. Happy to take any questions.
Okay, Debbie.
Hi, Ian. I was just wondering, you talked about 300 daily cases. I know before we had the pandemic, we spent a lot of time, haven't we, doing campaigns about the right person to the right pathway to get treatment. Have we got any data as to whether the number is so high because of the number of COVID cases, or is it because people are presenting in the wrong place, or is it because there's just a lot of people who haven't come forward, who are now much poorlier, who need A&E? I don't know whether you've got that information or it's something that's going to be looked into.
It's a good question. It's something that we reflect on a lot across all parts of the system, Debbie. I think the 300 attendees, which seem to become the norm at the moment, going up to 360 on really challenging days. I think if we look at that profile, which we have done, a lot of those attendances are appropriate attendances. There are attendances that could be dealt with in other parts of the system, but a lot of the other parts of the system are already absolutely stretched as well. So whether you're in mental health, whether you're in primary care, and then also it's people identifying the right pathway to go down. So, and also people kind of stacking conditions up over a prolonged period of time and then presenting late in a pathway. So I think that's, when we've looked at that through our A&E delivery board, I think that summarises people's views at this point in time. I think David's put his hand up as well. I don't know if it's linked to this question or another one, David.
Yes, I think my comments are similar. Certainly, YAS report quite high numbers of, which is the ambulance service, of category 1 and category 2 patients, which are the most acutely unwell. And I attend their sort of weekly A&E meeting, and every week they seem to be reporting a sort of small increase in those numbers of sort of acutely unwell patients that need transport to hospital. They're see and treat on the scene and trying to refer at the patient's home, and avoid admission seems sort of running at appropriate percentages. And sort of 111 also report high levels of activity. I think sometimes people are, to an extent, bouncing around the acute system. So people phone 111, they get streamed in to speak to a GP, and then there's a delay sometimes in that time by the time the GP's got back to them, and then they then represent to 111 or back into ED services. So I think it's just the general huge numbers of patients that are in the acute system that's causing the pressure. And certainly my experience of primary care is the numbers are really quite high, which is then just meaning that you haven't got much flex capacity when you've got people on annual leave or people are sick. So it's just big numbers of patients, I think, is the main issue. It's not necessarily that people are turning up in the wrong part of the system. There is some of that, there always has been, but I don't think it's any higher. But as Ian said, the numbers that are being reported are like winter, at a time when, certainly during August, quite a number of people are obviously on annual leave trying to get ready for the forthcoming winter, which is likely to be really busy.
Okay, thanks both.
Okay, any other questions for Ian? I think all that was just saying that the dashboard might start getting a little bit worse rather than better over the coming months, mightn't it, with all the things. So we just have to expect to support our colleagues in general practice and the acute trust as much as we can to deliver as much as they can during these push times. Okay, moving on, Sue.
Thank you, Chair. So starting with the quality and safety report, as you'll see within the healthcare associated infection section, there's some brief information about COVID. We are seeing some outbreaks within care homes and increasing numbers in hospital. There are incident management team meetings surrounding all of these with a partnership approach, and the CCG strongly linked into these through our infection prevention and control nurse. It's important that we all remain vigilant to the signs and symptoms of COVID and access testing for anyone with signs and symptoms, and that the guidance around social distancing and wearing face coverings where appropriate, it remains in force and to the front of our minds, really, to support the fact that we do need to protect ourselves, we need to protect our families, and we've just been hearing, we need to protect the NHS. We aren't in the clear yet, although the amazing response to the vaccination programme is certainly helping there. Work's progressing as well to deliver the flu vaccination to all groups identified within the guidance, and that also will work there together to help protect us all. As you'll note, the work by the Foundation Trust around mortality continues, and this does form a substantial discussion at the CCG contract quality meetings that are held with the Foundation Trust. The safeguarding section includes links to tackling violence against women and girls and the strategy around that, and information related to the Evolve service. And it's important that our children and young people at risk of both child sexual exploitation and child criminal exploitation are supported appropriately and involved in preventative work. The referral pathway to absolute advocacy related to independent mental capacity advocates, or IMCAs, is detailed within this section, and a link to a fact sheet about the Domestic Abuse Act 2021, which received royal assent in April of this year. The 7 parts of this act will come into force in stages to provide protection to those experiencing domestic abuse, and also to strengthen measures to tackle perpetrators. Page 8 covers updates about counter-terrorism and the PREVENT programme, and updates to the Child Protection Information System deployment, which is now at 100% across every local authority within England. And lastly, in that bit, the results from the learning event evaluations from the March PLTC event are included. Now, I can't open the links in my copy. If others are having, I don't know whether that's just my laptop, if others are having an issue, I'll include those in the next report to the next governing body meeting, if people can just let me know. There are links to the latest care home CQC reports and a summary of the report from the CQC visit to the Sheffield Health and Social Care Trust Assessment and Treatment Unit at First Hill, which has resulted in the CQC imposing conditions on the organisation. The CQC and Sheffield CCG continue to closely monitor the quality of care and progress against agreed actions there. A mental health homicide review, independent quality assurance review related to a full review undertaken in 2017 was published on the 11th of August. This assurance review concluded that there was considerable evidence and assurance of progress in implementing and monitoring the action plan. There's also a link to the quality assurance, this quality assurance report, which was also published on the CCG website. Towards the end of the report, there are summaries of progress by the Foundation Trust and Ardash against their action plans in response to CQC visits. TRFT are currently undertaking monthly reporting to the CQC on progress and are discussing with CQC colleagues at what point this may cease as they progress against these actions. You'll see on page 20 that a recent local area emergency protocol held for a young person resulted in actions taken to support them, and post-discharge they've been seen to be thriving in their new home. And lastly, we're beginning to work as an ICS model in respect of the Learning Disability Mortality Review. The Rotherham annual report is awaiting ratification prior to publication. This highlights areas to focus on in the future and also highlights identified good practice. I've recently taken over as the executive lead for LEADER across South Yorkshire and Still Bassetlaw, and with the excellent support across the patch, we'll be ensuring the continuity of processes and maintaining this focus on learning and improvement. I'm happy to take questions on any of that, Chair.
Okay, thank you, Sue. Would you like to make any questions, comments? give us a fairly good summary. I like you putting in compliments about our staff. Just need to get some more of them in.
Okay.
It's good that we get complaints and compliments. Anything else? No. Okay, do you want to move on then to patient and public engagement?
Okay, thank you. I'll just open the report. So the CCG is supporting Healthwatch currently in undertaking a piece of work to explore views and aspirations and expectations and how the pandemic may have affected these. It's been entitled Mind, Body and Soul and is trying to capture as many views by as many different means as possible. Some of the early feedback is in this report and the detailed full report will come to governing body later in the year when it's finalised. There are some examples there within the report and feedback about people still feeling more anxious about being in crowded spaces and physical contact such as hugging. There are also, interestingly, those like me who are happy with virtual appointments with their GP practice and a range of views and opinions that are coming through that have been collected into themes so that you can decide how best to deal with these and the approach to take. There was a meeting of the Communications and Engagement Committee in July where the key items discussed were vaccine coordination, that's a good one, COVID vaccination, social prescribing, ICS development, place communication focusing on mental health and the online Healthwatch Let's Talk sessions. The last PPG network meeting was in June and covered COVID update again, anxiety, GP access. There were discussions about all of these, data sharing in the digital world and how long-term guidance such as face coverings, as we've already mentioned, may affect us and be around for some time. The next meeting, I understand, is planned later in this month, but I'm sure Debbie will update us on that. The COVID vaccination clinics continue as the guidance expands to include more age groups. The Rotherham volunteer support to this continues to be really impressive. We've still got over 200 volunteers supporting this programme and they've given in excess of 21,000 of their own hours of their time to support this. And this weekend, we've seen at the Rotherham show, there will be a vaccination bus on site delivering vaccinations to all eligible people. This too will be supported by volunteers and GP practice staff from across the patch. And at the end, in the appendices, one of those is the Healthwatch August update.
Thanks, Sue. Debbie, do you want to add anything into that?
Sue's given a really good summary, just that, we're getting positive feedback when we're having these meetings with our PPG networks. We're getting lots of people attending. We're working closely, as Sue said, with Healthwatch. We're looking at things like lockdown experience, accessing services and what patients will expect in this new normal, which I think will inform planning very much so. So I'm working very closely with all our partners, not just Healthwatch, but obviously with community partners, TRFT, GP practices, etc., and obviously that fantastic volunteers programme. So it's a busy time. We are intending to have another PPG meeting. We're sort of saying maybe the end of September. We're waiting really to be able to share with people what's going to be happening with the ICS, but it's kind of a bit chicken and egg because we're not quite in a position to be able to pass that information and to give people a true understanding of an overview. So we may just do a coffee and chat session, which has been very successful in the past.
Jason.
Just to say to Debbie, if we are successful getting lung health checks, I'd love to come into a patient participation group and talk about that, if that's okay.
Absolutely.
Yeah, that would be good.
Yeah, always welcome.
Okay, any questions for Sue or Debbie? Okay, thank you, Sue and Debbie.
Thank you.
We'll move on then. Ruth, you've got a set of 3 papers.
Thank you, Chair. I can start with enclosure 14, the EPRR core standards. So this is the annual self-assessment and assurance process for emergency preparedness to NHS England. As you can see, we're reporting full compliance against the core standards again this year. Many thanks to Alison for pulling all this together. Unfortunately, due to the timings of the meetings and the deadline for submission, Aqua won't see these until next week. Governing body is asked to approve the core standards submission for this year. I'm happy to take any questions.
Okay, any questions? We're all very happy that we're fully compliant. So are we happy to approve this paper? Okay, see thumbs up.
Thank you, that's great. Shall I carry on?
Yeah, keep going.
So the corporate assurance report is for Q1, which is April to June this year. If I can highlight to you on page 2, we currently have 3 risks rated above the risk appetite relating to COVID and the impact on the strategic plan, SEND and sustainable services. We've also added 1 new risk to the assurance framework around the transition to the ICS. Alongside the continuing COVID pandemic, we also continue to work on emergency preparedness, not just with the previous core standards submission, but also I attended a regional table talk exercise organised by NHS England, which looked at a full hospital evacuation around reinforced aerated autoclave concrete. I get all the good jobs. The annual inspections are also reported in here, but I will come to them individually later on in the agenda. The numbers of FOI requests are steadily rising. We didn't have many during last year due to COVID, but they're now increasing back to pre-COVID levels. I think that's all I wanted to say. Happy to take any questions on that.
Great. Any questions for Ruth? Okay, thanks, Lee. Then Ruth, let's move on.
Social prescribing. So I wanted to take this opportunity to update colleagues on the work that's currently going on with other organisations in the Rotherham place to progress the social prescribing service in Rotherham. As you know, we've got the 2 main schemes running in partnership with Voluntary Action Rotherham, but we're also working on a few new initiatives to support the 2 main services and give access to social prescribing for more people. For me, interestingly, social prescribing is becoming more of a mainstream service, not as an add-on as it was originally. I'll pause for questions on that one.
Okay. I always look at Janet when you talk about social prescribing. Make sure she's smiling. We've not done anything wrong.
Sorry, I couldn't find where the reaction was. Yeah, I've got to say something. We've come an awful long way, haven't we? And really, it's quite incredible. Really quite incredible, and it's brilliant development. So well done to everybody.
Yeah, good. I would echo that. Anybody else want to say anything? Okay. I think we all remain, as a board, strongly supportive of social prescribing. It's done, especially with clinicians, it does wonders for people. Okay, thanks very much, Ruth.
Thank you, Chair.
Policies now, but it's not one of your policies. Ian's got to present a policy.
Yeah, thanks, Richard. I'll hopefully be brief on this one. So the Microsoft M365 platform is a new platform that the CCG has recently commissioned and has been rolled out across the organisation. This policy just documents how we expect the CCG data to be used in conjunction with M365 and also expectations of our staff using the M365 process. So we've been through our IG group, had several iterations of this. There's also a procedure here which is not for approval because that's agreed by our operational exec, but the policy is. So again, we've taken it through due diligence and governance, and we'll bring it here today for approval, Chair.
Okay, any questions, comments? It's just, these kind of updates are really important as we change across our IT, but I don't think there's anything in there. We just need to, as I keep mentioning to everybody, we just need to use all these things to their full extent and understand them a bit more. So we just need to get everyone trained up. Even Chris needs to be trained.
Okay, right. So I just need governing body to approve the policy, please.
Yeah, is everyone happy to approve it? Okay, yeah, we're happy to approve it then, Ian, thanks. Long COVID.
Okay, Thank you, Chair. So if I just introduce this now, I'll ask Dr. Litho just to comment as well, as he's been the clinical lead for this pathway. But as an intro into this, a couple of things just to flag. So obviously, as we've gone through the pandemic, sorry, can you hear me okay? I've just got a bad network connection. Yeah, okay. Apologies, it just came up with a bad network connection. So as we've gone through COVID, I don't need to remind members of the prevalence of long COVID. Nationally, there's a specification that's been developed and an expectation that each local place develops a long COVID pathway to support our local population. Significant work has taken place throughout different stages of the pandemic to try to support and manage patients experiencing long COVID. But this is now our kind of comprehensive pathway that we are putting in place across the borough. Governing body members will note that it comes with around £500,000 worth of funding. That funding is currently non-recurrent, so it is a potential risk to the CCG or future ICS in terms of funding the long COVID pathway. I think we should just note that today. I know we did that previously, didn't we, Wendy, in our operational exec notes, but we'll make provision for that within our future financial plans. But I'll just ask David really just to come in from a clinical perspective and just describe the pathway in a little bit more detail and to give assurance on the engagement of wider partners in the development of this pathway. Thanks, Chair. Thanks, David.
So long COVID's been discussed. I suppose it all initially started around 12 months ago when there was an ICS meeting which discussed how to implement long COVID services, because it was becoming apparent that a relatively large cohort of patients had prolonged symptoms, and they've now been defined and are in the paper, and there's actually not nice guidance that's also been written advising where acute COVID ends and long COVID becomes the sort of predominant condition, and it's generally a diagnosis of exclusion to exclude other conditions that can mimic it. The ICS decided that this would be delivered at place. So the places within South Yorkshire have all developed their own pathways. As Ian sort of mentioned, our pathway is now compliant with NHS's England commissioning guidance, which previously there was debate as to whether we were compliant due to the lack of an MDT within the system, but now there's funding available for this. The MDT is being created, mainly working with Rotherham Foundation Trust, who will be basing a MDT process within and working alongside breathing space, so that patients that the acute services know more about than primary care can also access long COVID services. But it's recognised that a number of patients will have never hit the hospital door, and due to low-level COVID, it didn't require admission, particularly those early in the pandemic where we were encouraged to try not to admit people to hospital. So the process starts from a primary care perspective, that the patient would have a set of investigations done, fairly typical of how patients present to primary care, fairly undifferentiated, to rule out any other conditions. And if long COVID became the apparent condition and their symptoms weren't resolving, then a referral into the MDT could take place. So the MDT is mainly therapy-based. There is medical input, and I understand the Trust has managed to recruit someone into that medical role. The risks from a staffing point of view are probably around the mental health aspects due to a national shortage of highly qualified psychologists to provide particularly things like post-traumatic stress disorder input. And there is, as Ian said, there's now treatment money, whereas previously it was only an assessment tariff. The non-recurrent nature is a risk. We don't really know how many of these patients are going to present. I think GPs are holding on to them in their practices, so there probably will be a number of referrals as the pathway is implemented, but longer term we're not quite sure how long and how many patients we would expect. It seems that vaccination does provide some form of protection from long COVID, but again, it's maybe going to be something to watch over the next 12 months. I certainly know that other areas such as Leeds are now reporting waiting lists of patients for assessment, whereas previously, obviously, when services were set up, patients were being seen in a fairly quick fashion. But I think the pathway should enable us to have a compliant pathway for patient care and should improve things for those people that have got prolonged symptoms, of which there are fairly significant numbers, I suspect, sitting in the community waiting for a service to come about.
Okay. Thanks, David, for that summary. I think it's one of these things that we need to note, that it's going to be an evolving picture as we know more and more about this disease. Any questions or comments for David or Ian? Okay, we'll note that. We'll keep an eye on it, but it's good that we're going to have that service locally. Okay. Now the highlight of the meeting, something about information asset and data flow assurance report to the ASIRO. That just seems like magic on the paper. Ian, do you want to tell us about it?
Yeah, thanks. It's an assurance one, which I won't keep colleagues on. So this just reflects the governing body work that takes place in the background to kind of manage our information assets and data flows across our organisation and keeping information safe and secure, particularly confidential information. So it just reflects the work that happens by the IG group, our information assets and how we treat them. There's nothing that I need to flag up to governing body in terms of any risk in this space. It's a routine process for us, but just for governing body to know for information today. Thank you.
Okay. Any questions or comments? Okay. I think it's just the important little bits of things going on in the background. You just need to keep an eye on. So thanks for that. Another important thing running in the background, health and safety inspections.
Thank you, Chair. So as I alluded to earlier, the annual health and safety inspections have been completed for Oak House. As you can see from the cover paper, there are a total of 4 actions for the CCG to take forward. The one high risk has already been completed. There's not much in there at all. We've not been in Oak House, so there's not been an awful lot of things to look at. I am happy to take any questions on that.
Okay, thanks. Any questions or comments on that? Okay, thank you, Ruth. Okay, just moving forward then from the minutes from other meetings. Janet, anything you want to bring up from the Primary Care Committee?
Thank you, Chair. I mean, these are minutes from May, so they're quite a long time back, and I apologise they didn't get to the July board. So I'm happy to take any questions to say things like at the meeting they approved the primary care annual report, which has been in lots of other domains now. Some revisions to less service specifications and proposed uplifts, and also around the deep vein tone process. I say that the meeting was quite a long time ago now, and I apologise for the delay.
Okay, that's fine. Does anyone want to raise any questions on that? Okay. Comms and engagement then, Debbie.
Thanks, Chair. I mean, it's been covered really, I think, in Sue's report, in so much as, yes, we met back in July, vaccinations, working with our partners and VAR, looking at how ways that with those partners we can support anxiety across the borough, healthier together and accessing services. So those sorts of things were on our agenda, and they're the things that we discussed and talked about with our partners.
Okay, thanks. Any questions? Okay, any delivery board in?
No, nothing to flag by exception that's not been reflected in the narrative already. Thanks, Chair. But happy to take any comments or questions.
Okay, thanks, Ian. Debbie, you're down for the Aqua Committee from May, again, a long time ago.
It seems a long time ago. It was a very busy meeting because it's the one really where we start looking at the end of the financial year. When we received the earlier sight of the annual accounts and reports, the end of year accounts detail, and head of internal audit report. We also took the Rotherham Send partnership report for the previous year, We did a detailed review of the new GBAF, looked at our draft annual report, and we also agreed the workforce race equality figures to go forward to NHSE.
Okay, any questions there? Okay.
Can I just add, sorry, Chair, can I just add that we were in awe in May of the work of the finance team in getting all of that ready after such a difficult year, and having it through and early, ready for our external auditors.
Yeah, they do an amazing job every year, don't they? And even more amazing job when they can't get to the local Domino's. I always tell when it's normal finding the cows because the Domino's menu goes out. For anyone who doesn't know Oak House, Domino's is around the corner. Keeps them going into the evening, doesn't it, Wendy? Okay. There's the ICS head minutes. Chris, anything you want to raise on that you haven't raised already? You're on mute.
Whoops, sorry. Yeah, the Chief Officer's report probably superseded a lot of information in there, but if anyone's got any questions, I'll be happy to take them.
Nothing. Then we've got members committee. I'll challenge David to do it, but actually, except that David wasn't there, I don't think there's anything particularly on there that hasn't been brought up. There was stuff again about COVID and the vaccinations and the integrated care system, how primary care will be represented, which is going back to GP members in September. Any questions on that? No? Okay. There's no one's raised any other business. So with that, and I don't think there's any urgent issues, anything needs to be escalated. So with that, we'll bring this to an end, and we'll just consider that representatives of the press and other members of the public be excluded from the range of the meeting due to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. I'll read that, and as we'll bring the public session to an end, and we'll restart the confidential session at 12:30 exactly. All right, I shall see you all in 10 minutes. Thank you.